to the ATCM channel. Today we are going to discuss a case of acute vision loss. Okay. We got a case of elderly females who came to the AR with the complaints of vision loss in the right eye. So on initial assessment, primary assessment, airway was able to talk in one sentence. Airway is patent and maintained, protected. Breathing wise, she is having respirate of 18 per minute, saturation 99%, and there is no any added breath sounds or any added difficulty in using of X-ray muscles or anything. Next, coming with the circulation part, patient was having 74 minutes per beat, heart rate and blood pressure of 170 by 90, and the skin color looks normal. Disability was GCS E4 V5 M6, bilateral pupil size was 3 mm and reactive, and symmetry was present. Exposure was temperature febrile and GRBS 185. So in the primary survey, there is no issue. She is also
GRBS is slightly high. That is the only problem. Is it diabetic?
Yes, a known case of diabetes. And next, coming with the secondary survey, ample history. Patient is a known case of type 2 diabetes mellitus, hypertension, dyslipidemia, rheumatoid arthritis, and severe. Last, she had a left parietal infarct, and she was having apical hypertrophic cardiomyopathy. She has no any allergies to any medication, and right now the medications taken by patients is apixaban in case of the apical hypercardiomyopathy.
Apixaban is given to prevent cardiac embolism due to apical HCM.
And for the diabetic control, she is on sitagliptin, metformin, and also the insulin, degludec, and aspartame. Now the past surgical history. She had already been status post right eye cataract surgery was done in 7th month of last year, where the phacoemulsification was done and PCIOL was placed. And even there was a past history of right eye status post vitrectomy and silicone oil injection. Post which again they had to remove the silicone oil removal because she was having proliferative diabetic retinopathy. In left eye there was laser proliferative diabetic retinopathy followed by intravitreal injections of bevacizumab was already given in the past.
So this bevacizumab is given already.
Yes. And regarding the last meal, she had a morning breakfast which was 30 minutes ago, prior to coming to here. And events wise, patient has a sudden vision loss, or as she was saying, it's a blurring of vision in the right eye.
So sudden vision loss is a very important problem in emergency room. Sudden vision loss. What are the conditions you get sudden vision loss? One can be in the eye itself. That is a common condition. Another one can be somewhere else a problem and that produces vision loss. So what are the problems here we can anticipate?
Here we can
differential diagnosis.
Either it can be this neurological component or the
so start from the retina, nerve, brain, like that.
Starting like first the media problem, cornea or the cornea keratitis, corneal edema, like acute angle closure glaucoma. Otherwise, it can be lens dislocations, trauma cases, any other. Then coming back to it can be the retinal problems like acute
retinal detachment. That is one of the hemorrhage, vitreal hemorrhage leading to retinal detachment. That is the commonest thing occurs in this type of condition like diabetes, hypertension, all these things, where there is a proliferation of the blood vessel that can bleed into retina and it can get detached. So that is the most common problem in our country. Then nerve, which are the problems? Optic neuritis. Optic neuritis is a very important problem where patient can have severe pain and visual loss.
Then we can have any kind of strokes which involve
artery and vein of the eye. Central retinal artery occlusion, central retinal vein occlusion.
Then we can go for retro like chiasmal. Then is mass presenting at the chiasma. Vision loss or retro chiasmal.
Then postcentral gyrus, posterior occiput area, posterior part of the brain, you can get stroke. So these are the common causes.
In this case, the patient was having blurring, like progressive in nature vision loss. It was painless, and there was no any redness of the eye. And along with this, there was a complaint. There were some flashes or floaters in the eye. Hence, making the differential diagnosis towards next. Personal history wise, patient has normal sleep, normal appetite, normal bladder and bowel. Habitual history, no history of smoking or alcohol consumption. Examination was general examination. Patient is normal build, weight of 71 kg with height 154. There is no pallor, icterus, clubbing, lymphadenopathy, or fetal edema. In CNS wise, patient had slurred speech, which was her baseline, previous severe infarct baseline was there. Vision was normal, memory normal, cranial nerves no abnormalities. In motor examination, power was grade 4 in left and grade 5 in the right lower limb, which was again a baseline kind of thing. In cerebral signs, patient was having ataxic gait and Romberg's positive. These are all baseline. So she was having the baseline of neurological problems.
Romberg test indicates what?
Posterior cerebellar.
Romberg test indicates
Posterior tract.
Romberg. Romberg is when you stand up and close your eyes, you are falling towards either side. That is the most common finding you get in peripheral neuropathy. Okay. Ataxic gait is a feature of cerebellar disorder. Okay.
Next, coming to the local examination, eye examination. The right eye was having pseudophakia, which we see in the history that she had cataract surgery done, and left eye was having senile cataract.
Okay.
And in visual acuity, right side there are only hand movements present in which they were having that vision loss.
Okay.
Left, but perception of light was present, so saying that the nerves were
normal.
Okay. And in left side, it was 3/16 perception of light was also present.
Okay.
Next, we examined in ophthalmologically the eye, in which the pressures were 19 mmHg in right and in left 18 mmHg. Anterior segment in the eyelids, there was adequate closure both sides. Eyelashes, there was no matting, conjunctiva, no chemosphere congestion. Cornea wise, there is normal luster in the right side, but both normal luster and transparency. Anterior chamber, normal depth. Iris, there are some patches of iris ectropia in the right side. Pupil wise, lateral both 3 mm direct reflex present and no RFPD. Lens is pseudophakic and right side. Left side, there is immature senile cataract present. And after dilated fundoscopy was done, in which it was showing vitreous hemorrhage features in the right side and the previously lasered proliferative diabetic retinopathy changes. And hence, we are confirmed the impression being the vitreous hemorrhage. Like basic topic wise, if we come in the investigation, we had a radiological ultrasound investigation showing these nutrous masses showing vitreous hemorrhage. And laboratory wise, HbA1c was 7.5. So her diabetes was under
not controlled, not fully controlled.
That is the reason causing proliferative diabetic retinopathy, which has caused spontaneous vitreous hemorrhage.
Okay.
Next, coming to the treatment wise, the ophthalmology department had gone with the right eye intravitreal injection of bevacizumab this time again. Okay. Under topical anesthesia. So bevacizumab dose is 1.25 mg initially we give, and every 4 weeks repeat depending upon whether it has resolved or not. Okay.
So previously also she has received
in left eye she had received previously, but now this time right eye vitreous hemorrhage, the right eye also received. In the acute vision loss, like topic of our discussion today, acute vision loss. In acute vision loss, we divide it as a transient or acute persistent.
Okay.
That is acute persistent when the duration of loss is more than 24 hours.
Okay.
And transients will call it less than 24 hours. Acute persistent, it is not because of transient ischemia, but in transient it can be like the vascular occlusions or neuronal depression. Neuronal depression might be after seizure or a migraine, both neurological and vascular compromise causing transient. Next, coming to the differentials, usually the vision losses we divide into unilateral and bilateral initially. After that, painless and painful. Painless conditions are like vitreous hemorrhage and retinal detachment or arterial venous occlusion, CRAO, CRVO, and ischemic optic neuropathy. Ischemic optic neuropathy is a painless. Okay. And when it comes to painful, keratitis is the major one, corneal abrasion because of any trauma. Acute angle closure glaucoma, open angle glaucoma is a painful condition. Endophthalmitis, when it involves the whole eye, that is again a painful. Optic neuritis is the most painful. Bilateral painless will be in the posterior and the central pseudotumor cerebri, metabolic or toxic causes causing the blindness, or chiasmal area, retrochiasmal etiologies.
We get many cases of methanol toxicity. If the patient is having metabolic acidosis, alcohol intake, and visual loss, then you will suspect methanol toxicity. Okay.
And bilateral painful, it can be when keratitis involving both the eyes. Keratitis due to contact lenses. Next, when we come to the approach wise in the history and examination taking points, history we need to check verification of the acuity. Like patient might be having one eye like blindness, but because he sees with both the eyes, he will not be identifying that he had a blindness in one eye. The transient loss, we need to clarify that laterality, bitemporal or which side homonymous, right immunopia, that one, and quality. Sometimes it can start in the periphery, so he might be having diminution of vision, and when it is involving like a nerve fields, it will be complete vision loss. If it is macula, it will be very concentric. Quality, how much quality of that vision loss, whether pain or painless, red or with redness is present, or redness involves saying inflammation of the superficial anterior segments of the eye. And what are the associated symptoms? If there are like involving systemic involvement, if there is a stroke involving eye and weakness, like associated symptoms, or if it's a giant cell arthritis causing ophthalmic legia, along with that they may have jaw claudications. Headache would be there. Other than that, if it's a trauma, regarding the trauma, there will be redness, chemosis, hypema, all those other features. And we need to see if there's a pre-existing visual problem. Pre-existing visual problems indicate that it might be an exacerbation of the previous thing, so the history will be helpful like that. And in the past medical history, vascular diseases should be seen like diabetes, these are they cause proliferative diabetic retinopathy, hypertensive retinopathy. These conditions will be increasing and progressive in nature. And the refractive status like myopia patients, myopia causes retinal detachment. And if they're having contact lens where the history will give us the help of keratitis, usually keratitis, bacterial keratitis is caused in contact lens. And next, coming to physical examination, general examination, as we have seen all the anterior structures, and checking the visual acuity will be useful if even using a pinhole also we should use after normal and pinhole. And evaluation of extraocular movements, is there any pain or what? In like endophthalmitis condition, there will be pain when we check the extraocular movements. And next, confrontation visual, I feel like we ask the patient to stand opposite to the examiner. We close both the same eye, will close and we'll check the field defects, peripheral defects, to see which side his vision loss is major. And regarding pupils, we check pupillary reflex.
Pupillary reflex is very important in visual loss.
In the pupillary reflex, direct pupillary reflex, usually that is conducted by optic nerve. The light which falls on the retina goes to the optic nerve. It will go to lateral geniculate ganglion, transmitted to pretectal nucleus. The Edinger-Westphal nucleus is the relay center where this reflex is communicated to the ciliary ganglion and oculomotor nerve, causing the pinpoints.
When you put the light, normally what happens to people? Okay, so that you can see in the opposite side. Suppose there is a visual loss due to a problem here in the periphery. In the peripheral systems, there is a cause for visual loss, like you are telling about the retinal detachment. So if we put a light, it will not transmit to this area. So that opposite side reflex or same side reflex itself will be absent. Whereas in the cortical visual loss, cortex there is a problem and visual loss is there. This part will be spared. So you get pupillary reflex will be present in that condition. So that is very important. You should remember that.
And the other things which you can check is RAPD, reactive apparent pupillary defect, where the eye which we are seeing, the light instead of this constricting, it will dilate.
Okay.
Next, other thing is fluorescein application, that is to see into aberrations. And then IOP testing, intraocular pressure testing, if it's open angle glaucoma, those conditions. And slit lamp examination, we can see red reflex. Red reflex will be suggesting, by absence of red reflex, we can suggest there is some mediopestis, vitreous hemorrhage, or there is a retinal detachment which is not allowing the red reflex to be seen. And ophthalmoscope examination, direct and indirect. Direct is a handheld thing where we'll see only focused area of the macula and thing. Indirect will be open, we can see even the peripherals of the retina.
So it is better to know about ophthalmoscopic examination of eye when you are working in an emergency medicine department, because normally ophthalmologists will see, but handheld ophthalmoscopy can easily make some of the diagnosis. Okay, not all like ophthalmologists, but major things we can pick up.
And recently we started using ocular ultrasound in many of the emergencies where we can see vitreous hemorrhage and
even optic nerve detachment.
And we can calculate the intracranial pressure facing optical nerve sheath diameter, and the visual evoked potential.
Visual evoked potential is very important, especially conditions like multiple sclerosis. Okay, when there is a demyelinating lesion. For any lesion, it is useful. Brainstem lesions can be picked up by this stuff. Okay.
Coming to the medications which are causing vision loss. Okay. Anticholinergics will cause loss of accommodation, cause some vision loss. Okay. Bisphosphonates cause uveitis, digoxin, yellow vision. And major ones like topiramate causes angle closure, glaucoma, and antiepileptics. Oral contraceptives causes ischemic.
This is very important. Somebody is taking oral contraceptives continuously. They have a chance of stroke, myocardial infarction, deep vein thrombosis. Here also it can be systemic problems.
And vision. Okay. And many cancer therapy that causes retinopathy. Okay. Coming to this optic nerve pathway and the lesions and different.
Here it is very important. You have to see that some of the important things, bitemporal hemianopia, that is very important for ER decision. The problem here, okay, especially CNS tumors, that can be this. That is very important. And optic nerve completely, when there is an absence of one side, you can think about optic nerve lesion. And no light perception of light, that is very important. That condition, light perception will be completely absent. Okay. And other things are not so important for a ER physician. Then macular sparing is another important problem. Macular sparing is the feature of cortical vision.
Cortical direct.
So that is also we should remember. Okay.
Anything else? Just coming to VEP, these are the graphs which we get. This amplitude and latency is the one which determines whether it is what are the abnormalities we can generate. Coming to this acute vision loss, the algorithmic approach. So first we have to see whether there is any recent use of contacts or surgery or trauma. If these three are present, then we can identify that the surgery is post-op. It may be any post-op kind of complication. If there are contacts, we should immediately see for abrasion or a keratitis feature. And trauma, the whole involving different parts of the eye. Then if there is not any of this, then we'll ask whether it's a painful or painless. If it is a painful thing, whether redness is there or not. If it is a redful, painful lesion, then we'll consider keratitis, hyphema, anterior uveitis, all the inflammatory conditions. If there is no redness, this is optic neuritis or the papillary. And if there is no pain, then we'll go to the neurological side of it, where if there is a homonymous field loss, then it can be this chiasmal, retrochiasmal level of the brain involvement.
Sudden loss of vision in emergency room is a very important topic. So emergency room, when the patient comes with sudden loss of vision, normally you think about like in diabetic patient, retinal detachment, hypertensive patient, retinal detachment. Somebody is taking aspirin, clopidogrel, maybe cholesterol embolia or something blocked. But patient who is having headache, that is a problem. Patient is having headache with sudden visual loss, can be migraine. So it's a transient visual loss. Migraine, so many migraine patients come to ER with transient visual loss. Without any major treatment, they will recover. That is the advantage. Whereas optic neuritis is another important problem. They have severe pain in the eyes with visual loss. So that type of conditions we should be able to at least think about differential diagnosis. Because most of the time we will not be able to do any major treatment for this because ophthalmologist has to intervene there. But whether to do MRI, CT, all these things depends on the ER physician. So if you are thinking about any other associated neurological finding, then MRI or CT may be required. If nothing is there, only eye problem you are suspecting, then ophthalmologist has to see. Sometimes visual evoked potential has to be done. But all can be done in a tertiary care center very fast.
So next, depending upon this various places like the media problems, retina problem, anatomically dividing the vision loss causes. Okay. And then starting with the media problems, if there's a corneal aberration, we can use the fluorescent stain to see this green color indicating that there's a corneal aberration there. And keratitis is this red, painful irritation in kind of a condition, so inflammation of the cornea. Okay. And most commonly keratitis are the infections caused by viral, bacterial, fungal, and bacterial, especially bacterial keratitis, is seen in patients who are using and it should be evaluated within 24 hours, this bacterial keratitis. Coming to the corneal edema. Corneal edema is the loss in, like because of this corneal swelling will reduce the corneal clarity and the vision problems are there. One most important reason for corneal edema is this open angle, acute angle closure glaucoma, in which the IOP is highly increased. And as an emergency wise, there is no ophthalmological intervention, we can start like treatment with, we start timolol 0.5%, 1 drop PGU and we'll wait for 1 minute. Still not relieved, then we go for alpha-1 alpha-1 agonist, then not then pilocarpine, then at last acetazolamide we start for 500 mg IV. This is the sequence of it. Next, hyphema is like the blood in the anterior segment of the eye. Lens change, even because of trauma entering the lens position changes, or sometimes even it happens naturally in the case of diabetes and everything. Okay. And then vitreous hemorrhage in this condition, like if there's a bleeding into vitreous humor, it can be because of trauma or spontaneous. Spontaneous, it is because of any neovascularization such as poorly controlled diabetes.
It's a common thing. In our country, it is a more common cause for vitreous hemorrhage.
And in vitreous hemorrhage, most commonly we see painless floaters or flashes of light, which will give help in differentiating this condition. And the reduction vision is directly proportional to amount of blood in the vitreous. More amount of blood, more loss in the eye. And there will be decreased light reflex because the light rays cannot be passing. We cannot see through the ophthalmoscope the retina. And we can use the help of fundoscopic examination with the retina. And in the case of vitreous hemorrhage, patients should be evaluated by ophthalmologist within 48 hours. There's some treatment must be given. Vitreous hemorrhage, and because of this hemorrhage, because that is the cause of the floaters, diffraction from the floaters. Next, uveitis also causes this. The different thing in the uveitis is which structures is involved. Anterior structures or posterior structures. If it is involving posterior structures, there will be decrease in the red reflex, and there will be comparing of new floaters or something.
So whenever patient come with SLE, rheumatoid arthritis, and Sjogren syndrome, all these things, whenever there is a visual loss or these things, painful visual loss, you have to think about the uveitis.
If it's involving the anterior chamber, we'll see a white blood cells collection in the anterior chamber. Okay. And in the posterior chamber, if it is posterior uveitis, we'll see the whitening of the retina or the choroid. Next, acute retinal necrosis. This is a rare and a serious cause where it is caused by herpes virus. Okay. It causes the necrosis of the retina. Like the pathologically, we can find this ballooning and the whitish color spots on the retina. Next, endophthalmitis. Endophthalmitis will cause acute persistent loss of the endophthalmitis is bacterial or fungal origin. It can be, and like signs wise, there can be edema, there can be conjunctival hyperemia, hemosis.
One of the common causes fungal infection, so that you have to remember, especially in diabetic patients, COVID infection times, steroid use.
Endophthalmitis is also like the most common complication post-op ophthal surgery. Next, when you come to retinal problems, it can be CRAO, retinal detachment, or acute maculopathy. In CRAO is similar to like CVA kind of a thing. Can be because of it like ischemia, hypercoagulability, or even giant cell arthritis can cause CRAO. In CRAO, initially the retina becomes ischemic, turning milky white, but post-op, like after a few hours, it can turn, there is cherry red spots appear, like cherry red spots on fundus, it's a CRAO. Next, in CRAO, because of the venous stasis, the blood will be collected and then it will cause the bleeding, that the blood to come out between the nerve fibers in the layers of the retina, causing cotton wool spots. That is termed as the blood and the thunder fundus. Blood and the thunder fundus. And patients having CRAO must be seen within 48 hours. And coming to retinal detachment, this is basically most oftenly seen in myopic patients. Detachment of the retina coming from this causing visual loss. And acute maculopathy, if the macula is involved, most likely when the macula is involved, there will be this blurred vision, visual distortion. Distortion is a sign that the macula is involved when the image distorted. Here, OCT is used for finding the cause of it. Next, coming to neuronal pathways causing vision loss, like optic nerve involvement. In optic nerve, we have two conditions: optic neuritis and ischemic optic neuropathy. Optic neuritis is the inflammatory condition. In this, the patients have pain on the eye movement. Optic neuritis is in 15 to 20% of patients with multiple sclerosis, this is the presenting features. And
Multiple sclerosis is a very important cause for this optic neuritis. And Devic syndrome is another syndrome which presents with optic neuritis. It's frequently same for multiple sclerosis or demyelinating neuropathy. Whatever it is steroid sparing agents, and monoclonal antibodies like that.
Here, other thing in optic neuritis, important sign we see is apparent pupillary defect, which is causing the RAPD and the pupillary reflex. Here, we use diffusion weighted MRI to as a test. And we can identify using diffusion weighted MRI and post contrast enhancement for the intravic segment of the neuron. It's the intraorbital segment of the optic nerve, which part it is involved. And regarding the ischemic optic neuropathy, it is the same like the ischemia of the optic nerve. This is seen in most likely in elderly people, and it can involve this anterior segments of the eye or the posterior of the eye. And it will even giant cell arteritis can cause this. Even vasculitis conditions can cause ischemic optic neuropathy. Other thing which is causing optic nerve problem is the papilledema. Whenever the ICT pressure increases, pressure on the eyeball causes the increase in that causes papilledema. So in papilledema, when you see a patient in papilledema with vision loss, we need to take an MRI to rule out any mass lesion is present in the brain or anything causing indirectly this vision loss. Next, chiasmal or retrochiasmal. Chiasmal like the pituitary lesions, these all causes bitemporal.
That is very important pituitary lesions. Since we have a very good neurosurgery center, we get a lot of cases of chiasmal tumors.
Characteristic finding in chiasmal lesions will be
bitemporal hemorrhage. Both sides it will be like both sides it will be absent. Okay. Here it will be absent. Here it will be absent.
Most likely it will be a progressive kind of thing in chiasma, but along with the chiasma, if there is any defects of ocular motility, then we need to consider that the cavernous sinus region of the brain.
Cavernous sinus thrombosis very commonly we get in pregnancy, post-pregnancy, pregnancy period. Okay. So there will be eyeball will be pushed forward, or proptosis will be.
Next, coming to cortical blindness, which will be rarely seen, but it is most likely in Anton syndrome, it is a finding of cortical blindness, where the patient will be confabulating that he is not blind, but he is actually blind.
Denial of blindness, that is very important.
And the other is a psychogenic blindness, where there will be a functional visual loss, but if patients are purposely doing it, we call it as malignance. If it is truly there, which is there, then it can be a symptom of a conversion disorder.
Okay, so in that condition, you can do Meniere's reflex. Meniere's reflex is what? So these are the eyes. Okay. You just tap on the face. Don't touch the face. Just do more close. Suddenly, if he is malingering, he will close his eyes. Okay. So his eyes will be completely closed. Okay. So his eye will be completely closed. When you try to tap on the face without any information, suddenly if you do like this, they will close the eyes. That is a reflex. Okay. Then you know that there is no visual loss. Okay. Okay. Thank you.